All right. So my father had an out-of-hospital cardiac arrest when he was 34 years old. My mom performed bystander CPR. She then rode in the ambulance and was ushered to a small emergency department waiting room. I was 2, and my brother was about 6 months at the time, so we were sent over to the neighbor's house. My mom sat in the waiting room for what I can only assume felt like an eternity. And then a young emergency physician entered the waiting room, called out for the family of my father, approached my mom, and told her that my father had died. She remembers every single thing about this conversation. She remembers all of the words that he used, all of the phrases that he said, exactly how he looked, everything down to a splotch of blood on his left shoe that she always assumed was my father's. So flash forward about 22 years, and I'm a third year at Georgetown Medical School, and I'm in a small group. It's a medical malpractice elective. And we're kind of just going around the table reading cases out of a textbook, like elementary school style. So it's my turn to read. I flip the page and start to read, and it's my father's case. And luckily, my name had changed through marriage, and I was able to hold myself together, read the case, discuss it. Everything that was written in this textbook was news to me. So, of course, after class, I call my mom and I'm like, what the heck? And she knew about all of this. She knew that medical mistakes were made. She knew that there was equipment failure. And she had forgiven the system and had forgiven the physicians for this. You know, she told me, Hayley, these are young, educated people who were doing the best that they could at the time. However, she never forgave the physician for the way that he told her that my father had died, the way that he walked into the waiting room, stood towering over her, gave her the worst news of her life, and then left without any answers. So today we are going to learn how to properly break this bad news in the emergency department. You all are going to leave this lecture being absolute pros at giving the death notification. And I'm also going to continue to emphasize that, especially in cases of a prolonged downtime, how you handle this conversation with the family is often more important than the medicine that you use during a code. Your job does not end when you call time of death. So for a brief agenda, we are going to go over what bad news actually is. We are going to go over a popular and evidence-based protocol for breaking this bad news. We are going to briefly discuss family witness resuscitation as well as debriefing. Now, the first thing that we must recognize is the scope of this bad news. We break bad news all of the time. We probably break it 3 to 4 times with every single patient encounter. So this is my definition of bad news. Bad news is any news that adversely affects an individual's view of his or her future. I'm sorry, ma'am, but your CT scan shows that you have cancer. Sir, your first troponin level was normal, but we're actually going to have to keep you here in the department for a few more hours, and you're going to have to get your blood drawn again. I know this is not what you were expecting, but you're actually going to need to be admitted to the hospital today. I'm sorry, sir, but I'm going to be discharging you home. I'm sorry, ma'am, we're actually out of turkey sandwiches. All of your blood results were normal today. I apologize. I don't know what's causing your pain. I'm sorry, ma'am, but your husband has died. So if we do this all of the time, then why is it so difficult for us? In 2010, the University of South Florida did a 5-hour grand rounds with their emergency physicians about breaking bad news, and it scored very highly on a 1 to 5 Likert scale. Before the grand rounds, most emergency physicians said that they had 0 training before that grand rounds. And afterward, almost all of them said that after a lecture style and a sim on breaking bad news, they will be better physicians because of it. So overall, 1/3 of emergency physicians have training in residency, only a half have training in medical school, and then 94% feel as if they could benefit from some training. I personally had a lot of training in medical school and breaking bad news, but none of the training involved breaking a news of death, and none of them were simulated in an emergency type room, like in a hectic environment. So last year, when I was rotating in the surgical ICU, one of my surgical co-residents had a patient die, and she came up to me and was like, "Hayley, what do I do next?" And I was like, "Okay, yeah, you call the family, you call the medical examiner, and you need to give WRTC a call at 703-641-0100, and you have to do that within an hour." And after I told her the steps, I kind of sat there and I self-reflected, and I'm like, my goodness, I had this entire process memorized. I have the phone numbers memorized. Clearly, we do this so often. So why is it so hard for us? 70% of emergency physicians find that the death notification, plays an emotional toll on them. And that's because deaths in the ED are generally unexpected for the family. Nobody wants to die in an emergency department. Nobody plans to die in an emergency department. The patients tend to be younger. Generally, we do not have a pre-existing relationship with the family or with the patients. There's inadequate physician education on how to give a death notification. Time is short in the ED. Quiet is absolutely impossible. We have a fear of blame. And then also, we generally are not able to answer very many questions when it comes to the cause of death. So there was a cross-sectional study in Brazil that surveyed 73 physicians and 69 family members and 4 patients after they had a bad news conversation. And most of these were a death notification. And the findings were really interesting. The physicians actually rated themselves lower than the families rated the physicians, which tells me that we are leaving these conversations feeling as if we failed. Also, the physicians and the families agreed that the physicians had a great abundance of knowledge. They were able to answer questions well. However, where they failed were in the categories of emotion, invitation, and setting. So after a literature review, nearly every single modern day article uses something called the Spikes protocol. Now, nobody has the time to use the Spikes protocol when we are breaking the news of needing a second troponin or no turkey sandwiches. However, I always use this when I am giving significant news, namely the death notification. So we are going to go over this protocol today. So the S stands for setting, or setting the stage. And one of my biggest pet peeves in lectures, such as this one about breaking bad news, is when the speaker tells you that you need to find a quiet room, because we all know that that's absolutely impossible. The first time I ever gave a death notification as a physician, I was an intern, and I was excited to hear that we had something that was a self-designated quiet room or family room outside of the emergency department. So I assumed that I would just use that. So the family arrived, I walked them over to this quiet room, I opened the door, and there were multiple police officers, there were patients in orange jumpsuits and handcuffs, and it just completely started the conversation off horribly, because then I was prancing them around the ED trying to find a place to talk. And so now I always find my room prior to the family's arrival. I always have a spot in mind. Generally, I'm cleaning out patient rooms or I'm taking them to a triage room. It is important to note that one of the biggest patient complaints that we receive is that they received bad news in a hallway. So I never break the news in a hallway, and I absolutely never tell them this news in the waiting room. So during this part of the protocol, you need to introduce yourself and you need to tell them your role in the patient's care. You also need to figure out who is who. You don't want to be breaking the news to the patient's neighbor if they have closer family who's on their way. Prior to COVID, I would always shake their hand, and I still do sometimes if I feel like they would be down for that. I just kind of see what my general sense is, and then you have to make strong eye contact. So, hello, my name is Dr. Harvey. I shake their hand. I look at them in the eyes. I'm an emergency medicine resident who has been involved in the care of Mr. Smith. How are all of you related? A question that I commonly get here is about the white coat. Should we be wearing the white coats during this conversation? There was a survey-based study published in 2013 that found that 69.9% of patients want their physicians to wear a white coat when they're breaking this news. It actually gives them comfort and a sense of authority that they want during conversations like this. Now, I personally am not a white coat wearer. I feel really weird wearing the white coat. However, I've kind of changed my tune on this, and I always have a nice white coat available for conversations like this. And in cases where I don't, I just make sure that my scrubs are clean and that my physician badge is clearly visible. So P stands for perception. Asking the family what they know prior to you delivering the news is exceedingly important. I am often surprised. Sometimes the family members already know that their family member has passed, and other times they're completely clueless. They think that they're there with a cough or they're there with gastric reflux, and then you know that you really have a long way to go in delivering this news. So I generally say something like, what is your understanding of why your husband came into the emergency department today? You need to use open-ended questions. And this part can be exceedingly painful because if they have no idea, they may be going on and on about, my husband always coughs and it keeps me up at night and I just couldn't take it anymore. And so I told him he needed to go to the emergency department. How is he doing? So this part is exceedingly painful. You cannot interrupt them. You cannot correct them. You need to sit there, listen to them, make strong eye contact throughout their entire spiel. Also, I make notes of their vocabulary and their assumed education level during this step because it will be important when you're delivering the information. So I stands for inform. And there was a study out of Turkey that interviewed 760 patients and patient families and asked them how they want this news delivered to them. And unfortunately, 51.2% said that they wanted a chronology of events. So that means the other half just wanted the punchline that their family member had died. So this means that we have the potential of failing, 50% of the time. So generally what I do is during the perception stage, the step right before this, I listen to their perception, why they think their family member is in the emergency department. And if, they were performing bystander CPR and they're crying and they're asking you if their husband is alive, you do not need to give a whole chronology of events. That's when you need to tell them that their husband has died. However, if they think their husband is there with a cough, it would be more reasonable to kind of go through the state that their husband was in when he got there, what labs, resulted as, and what the diagnostics showed, and kind of go through a chronology so that they can better understand. Something that I always do is I give like a foreshadowing statement. I'm afraid I have some bad news, and I see how they take that. And then I decide if I need to start at the beginning or if I can kind of just jump to the punchline. It's important during this step to always use appropriate language. You have to use layman's terms such as breathing tube, heart attack, clot busting medication. And most important, this is probably the most important thing I'm going to say, you have to use the D word. You have to say dead, died, death. You cannot use other terms such as passed away, passed on, in a better place. One time I was in the pediatric ICU on a rotation, and the attending told the mother of a patient that we lost her child. And she, became hysterical, like screaming and crying. And the care team was under the impression that the mother was reacting to a death notification. But it became very clear that she thought that we had just physically lost her child. And so to be able to back that up and say we didn't lose your child, but your child is dead, you just absolutely cannot recover from that. So you always have to use the D word. The last note I'm going to make here, before residency, I heard the phrase despite our greatest efforts a lot. And I think it's probably fine, but I just want everyone to realize that that can come off a bit defensive. We don't need to defend our efforts and tell a family member that we did everything that we could. I think we commonly say that because it makes us feel better. But they expect that we did everything that we could. And if there's any question about that, it's better for you to go through what you did instead of just making a blanket statement that you did everything that you could. So you've already broken the news and you've used the D word. You need to pause and allow the family member to react. And then you need to answer any questions. This is the part that most physicians score very highly on in surveys. We're generally pretty good at answering, medicine-based questions. However, this part, we generally don't have a lot of answers. I want to make it pretty clear that it is very rare for autopsies to be done. Private autopsies are $3,000 to $5,000, and many of our families are unable to afford this. And so you are likely the only doctor and the last doctor to be able to give this family any answers or any closure. So they deserve to know the facts that you know. If the EMS, EKG, showed, a STEMI, you need to tell them that. That's a fact that you know, and they deserve to know that. If you did a bedside echo during the code and it showed a huge RV, they deserve to know that. So I just want to emphasize that this is not a time for you to guess on the cause of death, of course, but you can certainly provide them with the facts that you know. So E stands for empathy, and this is the part that physicians score the lowest on. And I think this is pretty overthought. I think that we're all at a stage in our lives where we're able to step outside of ourselves and to put ourselves in the shoes of somebody who is truly grieving. Now, I am not like a soft, squishy, hugging type of person, but I have certainly found myself hugging families in these moments because that is what they need. I've bitten my lip to keep myself from crying. I do absolutely everything I can to show them that I care and that I'm there for them. So my biggest piece of advice here is to step outside of yourself and to give the family what the family needs in that moment. So S stands for summary and strategy. So this is generally where they're going to ask you questions about next steps. Will an autopsy be performed? They'll ask questions about police involvement if it was suspicious, or even difficult social questions like, this person was my sole source of income. What am I going to do now? Or I don't have my keys. I can't get into my house. So one thing that I do is I make sure that all of their questions are answered and that they have a ride home. My mom was left in that waiting room years ago without keys, without her phone, without a wallet, and she had just received the worst news of her life and she had no way to get home. So I always make sure, just like I do all of our patients, that these family members have a way home and they really should not be driving. One question that I received prior to this talk was, is it ever, not appropriate to bring a chaplain into the conversation? And during this step of the Spikes protocol is when I ask if they would like a chaplain. My mom was saying goodbye to my father and they sent in a chaplain, and she's not a religious person. And so she had to say, goodbye and in front of a stranger. And that's basically how she describes it. And so I never just automatically assume that they want one, but I always ask because I do realize how great it can be for some. So this is the Kubler-Ross grief cycle. And I bring this up just to show that all of these reactions are normal. We have no idea where on the curve our family members are going to fall. This may have been a rather expected death, and maybe they have already accepted it. Or this could be completely shocking to them and they're going to deny the news when you tell them. So you have to be prepared to have a reaction that falls anywhere on this curve. So unfortunately, with COVID, the COVID visiting rules have really thrown a wrench into breaking this type of news to family members. Despite allowing, an end-of-life visit in the emergency department, we're commonly breaking this news over the phone now, which has its own challenges. So here's just some tips about breaking this news on the phone. So first off, you must speak very slowly and clearly and allow the family to adapt to the situation, especially if you're calling in the middle of the night and you're waking them up. Just like you would in person, you're going to introduce yourself and you're going to identify with whom you are speaking, and you are going to ask them if they knew that their husband was coming to the emergency department that evening. You're going to see what their perception is. And then it's important to let them know that you would rather be speaking with them in person and offer that to them. Now, I find that when I say, I would rather be speaking with you in person, are you able to come to the hospital? It kind of serves as a warning statement. Like they know that that's probably not good news. And so I've never had anybody be like, yeah, I'll come to the hospital and get the news. Almost everybody wants to know the news immediately. So then I break the news exactly how I would in person, using the D word and sitting on the phone, allowing them to react, and then asking if they're able to come to the hospital. It's important that you tell them that you are there and that you are willing to answer further questions when they get there. A question I've received is, what if this patient dies at 6 a.m. and your shift ends at 7 a.m. and the family's going to get there at 8? Like, is this something that you can sign out to the oncoming doctor? And my answer is no, unless there's, extenuating circumstances. I would stay because the family deserves that. So the only thing better than detailing a resuscitation to a family after the fact is actually letting them watch. So this is always one of my priorities during every single code or an impending arrest. One time as a PGY2 at Southern Maryland, we got an EMS call, and it was about this lady who had been found dead in her home, and it was a 50-minute downtime with EMS, and she was found dead. So we don't even know like how long she was down before that. So as I was gathering my team and assigning roles, my attendant came up to me and she was like, okay, Hayley, what's your priority when they roll the patient in? And I was like, well, I'm going to ask EMS who found her and if family is coming in. And she looked at me like I was crazy. And she's like, no, the priority is A for airway. And then she made me go through like the ACLS protocol. And so it made me laugh because I realized like how this is not always thought about by everyone, right? This is always one of my biggest priorities, especially in prolonged downtime. So the patient gets there and she actually had lividity. So she was down for a very long time. And I did my due diligence. I verified the ET2 placement. I went through my H's and T's. I did a bedside echo. But my priority was finding the family and running the code for a couple of rounds in front of the family and talking them through it. So just some data behind family witness resuscitation. So one survey surveyed 984 critical care and emergency nurses out of California, and all of them said that their hospital did not have written policies on this. Most had done it, and all would allow the family to come in and witness it if given the option, and most said that they actually are confronted by family members asking to watch. In 2011, there was a review article published in Annals that was composed of 20 survey-based studies, and they found that families do want to be given the option. And then once given the option, they generally stay in the room. So I find that one of our fears is that we're going to traumatize them, that they're all going to run from the room screaming, but this did not show that. This shows that they generally will stay in the room, and they actually report favorable experiences, and they believe that it does help them cope. This review also found that nurses have a more favorable view than physicians. And I've asked a lot of nurses about this. And what I've found is that physicians are generally in the room, running the code, doing the procedures. And many of our nurses are standing outside of the room and they're acting as runners and they're managing the code cart. And they're the ones that are having to deal with the family members standing outside the room, asking for updates. The security guards saying that the family members are in the waiting room asking for updates. And so it may just be that we don't know that this is happening. So it's important to realize that it likely is. And then the last finding was that older physicians have a more favorable view than younger physicians. And that's likely because younger physicians are more nervous about running a code and doing procedures in front of an audience, but I think we can handle it. So our last topic today is going to be on debriefing. And there was an article published in 2014 in Annals that showed only 25% of emergency department physicians debrief. And it has been proven to help healthcare workers in their own grieving. So the way that I do this is different depending on if the family is in the room or not. If the family is in the room, I call time of death, I clean up everything very quickly. I cover the patient with a blanket to make them look, more comfortable. And then I tell the family that I will be outside and I am ready to speak with them when they are ready. And then I leave the room quickly to give them their moments. I then try to find all of the nurses and I either do a debrief as a big group, or if that's just not going to happen, I go up to each and every single one of them, including the techs, and I ask them for feedback. And I ask them, how they're doing, if they have any questions, any comments, and I just do individual debriefs. Now, if the family is not there, I've actually started doing something that one of the Washington Hospital Center attendings does, and he always does a moment of silence. And so you call time of death, everybody is generally standing around the patient, and he says something along the lines of, "We did not know Mr. Smith in his life, but we were lucky to be here during his last minutes. This is about to be one of the worst days of his loved one's life. So let's pay our respects." And we stand there, 20, 30 seconds of silence. And then I generally ask for feedback, any comments, any questions. And I just find that that allows everybody to move on and have a better shift than if you're just like running out of the room and trying to get all of the stuff done that you missed because you had spent a long time in the code. So my overall advice is not, to have memorized everything in this talk, but instead just to recognize the importance of this part of our job. We break bad news without even realizing it in the emergency department, and it's really hard to do, but it's not about us. It's about the family. So we need to follow the spikes protocol. Every person is different, so we need to do what feels right in the moment. We need to allow families to witness CPR. We need to debrief. I try not to look at any of this as a time sucker or a drag on my day, but instead an opportunity to do this correctly for the family. Our job does not end when we call time of death. These are my references, and those are my two sons, Liam and Winston. Thanks, guys.